So welcome back, everyone, to our first keynote presentation. And I'm pleased to have the honor of introducing Dean Michelle Williams to all of you, though for most of you she needs no introduction. As you know, Dean Williams is the dean at the Harvard T.H. School of Public Health, and she's an internationally renowned epidemiologist and public health scientist. She's been an educator throughout her career, and an award-winning one at that, and widely recognized for her academic leadership here at Harvard and well beyond. Prior to becoming the dean in 2016, she was a professor and chair of the Department of Epidemiology at the school, and a program leader of population health and health disparities research programs, also at Harvard's Clinical and Translational Science Center. I have the pleasure of being a secondary faculty member at the School of Public Health, so Dean Williams is my dean as well. And I can tell you that over the last years that she's been the dean at the school, she has been a transformative leader for all of us, really shaping the school to become even more of an inclusive research and scholarly community. She has sponsored generation and created pathways for successive generations of public health leaders and researchers. And she has championed the idea that all of us, particularly in this day and age, must practice a form of engaged scientific citizenship. In addition, many of the frontiers that Dean Williams is really putting forth for the School of Public Health have a dimension that is resonant with mental health, practice, psychiatry, psychology, and so forth. And I'll just mention two of them here. There are several others which are available on the school's website. The first is an initiative that will focus on overcoming violence, and then a second one on cultivating well-being and nutrition. So with that path-breaking collaboration, I think Dean Williams is inspired choice to talk with us here about public health and public mental health in the context of this conference. So please join me in welcoming Dean Williams.
Kim, thank you for that very generous and lovely introduction, and good morning, everyone. It's wonderful for me to be here. I so enjoyed the previous session, and Shelley, when you invoked dosage, I couldn't help but think of Paracelsus's statement and gift to all of us to remind us that anything at the dose, it can be a poison. And that is not just applicable to basic toxicology, but as well to our use of technology and other devices in our lives. I also was reminded when Kim was sharing and setting up that final question in the session, the irony of those who have means picking up on potential adverse effects earlier than those who are in disparity communities. And as a maternal and child health epidemiologist through and through, I couldn't help but remember the episode that I lived through in my early career, and that is watching that sort of divergence in breastfeeding versus use of infant formula feeding. And so it's really remarkable when you think about population health, public health, you end up having to cover a wide range of academic and professional domains. And that's what I saw and heard in each of the talks this morning. So Justin, I want to congratulate you on putting together this conference. And I regret that I won't be here for the rest of the day and a half, because this first opening session was just absolutely fantastic. And I'm honored to be here. Thank you. I get a chance as dean to try to give in this keynote a conceptual high framing presentation, which I'm happy to do because I hope that it complements well the very deep and broad perspective that each of the speakers brought this morning. And so what I'd like to also do before I get into my remarks is to thank you all and recognize that we have a diverse group in this audience that includes clinicians, advocates, engineers, and academics who together are working to shape the future for mental health care. And I would like to put an accent on mental health wellness. The people in this room I want to acknowledge represent a multitude of disciplines. We come at this topic from a wide range of perspectives, but all of us share an acute awareness that mental health is one of the most pressing issues of our time. We are confronted with this reality every day in our research, in our hospitals, and in our own families and communities. You had some statistics, and I just want to share a few more, that we know that mental health disorders are the leading drivers of poor health and disabilities around the world. And you heard some of that in Vikram's remarks. Today, more than 450 million people across the globe suffer a mental health condition, a number that is on the rise in just about every country. And you heard and saw in Vikram's talk that by 2030, our failure to address this will cost the global economy an estimated $16 trillion. But when we talk about the global burden, the macro level economic trends, it can also be easy for us to lose sight of the individual and human cost of this crisis. Lately, I've been thinking a lot about a book I read at the beginning of this fall semester. It's a book by Beth Macy entitled Dope Sick. And for those of you who aren't familiar with this book, it's a deeply moving depiction of America's opioid epidemic and the young lives that it has taken across Appalachia. I keep thinking about one particular scene very early in the book, written by this gifted journalist. And it's when Beth, the author, joins a woman, her name is Christy Fernandez, at the grave of her 19-year-old son. Through her tears, Christy talks about Jesse, the high school football star, the burly construction worker who had his whole life ahead of him. Christy is tortured by the grief, but also by so many unanswered questions, namely how her boy, who'd never missed a day of work, could suddenly become a heroin statistic, slumped over in someone else's bathroom floor as he died. Countless of families are wrestling today with this same unspeakable heartbreak. For the first time in decades, life expectancy in the United States is on the decline. The spike in mortality is driven by early deaths among poor and middle-class Americans. A large number of these deaths are among young and middle-aged white Americans without college degree. This group is plagued by what Ann Case and Angus Deaton from Princeton has termed as deaths of despair. Many are grappling with the loss of powerful work, purposeful work, as coal miners and steel mills close, the pathways for middle class dissolve. They are suffering from relentless financial strains. They're watching a growing chasm, Shelley, that, the image that you invoked in your closing remarks of the last session. Chasms as wide as the Grand Canyon between their lives and their dreams. And that really has turned many towards alcohol, substance abuse, and suicide, as was mentioned earlier. I mention all of this because it illustrates something that researchers are just starting to truly understand and grapple with. And that is the profound impact of stress on our mental and behavioral health, and perhaps even more astonishingly on our biology. Stress, of course, takes on many forms, and this audience more than most knows this. We use the term stress to describe our response to all sorts of short-term, fluid situations, from the headaches of our daily commute to the pressures of taking a tough exam. But chronic, unrelenting stress, the kind that comes from financial despair or sustained violence, can lead to wear and tear on our minds and on our bodies, contributing to a cascade of adverse health outcomes, among them heart disease, obesity, and stroke. And for those of you who study women's health in particular, there are even replicable findings of stress having deep impacts on women's reproductive health, including driving premature ovarian failure as just one profound gender-based example. Two Harvard Chan researchers have done groundbreaking studies on trauma, and more specifically, looking at the prolonged effect of PTSD. Kirsten Conan, pictured here, is a professor of psychiatric epidemiology in the Department of Epidemiology and the Department of Social and Behavioral Sciences. She and Andrea Roberts, a research associate also in the school, together are looking at the connections between trauma and physical disease. Using the data from the Nurses' Health Study, they've compared the rates of type 2 diabetes, cardiovascular disease, and obesity in women with and without PTSD. And what they've found is that those women with PTSD are twice as likely to suffer diabetes as the general population, and that women with PTSD also have a 50% higher likelihood of stroke or heart attack, and that they have a 36% greater chance of becoming overweight or obese than those without PTSD. Dr. Roberts has also used these findings to further explore the aftermath of trauma across generations. And what she's learned is that the physical effects of trauma doesn't stop at the individual, but they can continue down to that next generation. Her research has shown that just as abuse survivors have higher rates of obesity, smoking, and substance use disorders, so do their children. And the severity of the abuse matters. The more severe the abuse, the worse the health outcomes. Unsurprisingly, this now well-documented multi-generational effect of trauma are caused by many behavioral mechanisms. For example, a person who experiences trauma may suffer from depression, PTSD, or other mental and physical conditions. Those conditions can affect the way that they parent, and therefore affect the health and well-being of their developing children. But new studies are also suggesting that there may be other pathways for trauma to pass from parent to children. Dr. Roberts' latest research shows that the child abuse may actually leave molecular scars, if you will, on the DNA of male survivors, suggesting that health problems resulting from trauma could conceivably be passed down genetically or epigenetically. Dr. Roberts and her research team examined the DNA of the sperm of 22 men who had suffered some sort of abuse as children. In those samples, the team found 12 areas of the DNA that had undergone methylation. For those non-clinician, non-scientists in the room, methylation is the process whereby a structure called a methyl group is added to a strand of DNA, which can then influence gene expression or gene function. These changes are not seen in the structure, in the DNA of men not exposed to child abuse, but actually resides at a higher frequency in men exposed to child abuse. Additionally, these studies in humans, and these are observational studies, have been replicated, the findings in mice, where the DNA methylation in sperm cells have been identified to contributing to change metabolism or biological problems in the offspring of exposed mice. So these findings, along with a growing body of research, suggests that stress not only impacts our mind, but also our metabolic system, and it can actually change us at a molecular level, helping us understand how stress and trauma gets under the skin and affects behavior and health. So, everything we are learning about the connection between stress and our biology reinforces a central fact, and that fact is improving public health must begin with improving brain health. And yet, we know that mental health conditions are not treated with the same urgency or gravity as physical conditions, that the diagnosis and the treatment remains insufficient and inaccessible for millions around the world, as you've heard in our earlier session. I want to take a look at who are the people not receiving a range of mental health treatments. This is not for lack of science that there is a treatment gap. The efficacy in mental health care is well documented. As the folks in this room all know very well, a range of mental health treatments exist today, from medications to psychotherapeutics interventions to social and community-based support interventions. Collectively, these interventions have been proven affordable and cost-effective. And most importantly, they've been shown to make profound differences in people's lives. But even in the world's wealthiest countries, as you've heard, most of those in need for treatment aren't receiving these treatments, or any treatment at all, in fact. And in the United States, it's estimated that more than half of the people with a mental illness do not receive treatment. An enormous treatment gap in an environment where we have the resources. And this reluctance for many to get help stems from some very real institutional barriers that I will talk about. But I first want to talk about stigma. Stigma is and always has been a formidable concern. In both low and high income countries, people suffering from mental health disorders have long been ostracized, isolated, and even punished. In some countries, mental health disorders can be grounds for denying people the right to vote, or expelling them from social and professional associations. And in other countries, a marriage can be annulled if a woman has suffered a mental health disorder. These issues aren't relegated just to the developing world. Here in the US, people with mental issues still face social rejection, limited employment, limited educational opportunities, and discrimination in housing and health insurance. They're often mocked in the media or portrayed as dangerous or violent. Many people who suffer mental health conditions internalize these manifestations and negative attitudes, resulting in self-stigma. Some become so embarrassed or ashamed that they try to hide their symptoms rather than to seek help. And for others, mental health issues are so seldom talked about in their communities that they may not even realize that they have the condition that could be helped, that could be alleviated with effective treatment. The implications of stigma aren't just social, they're also structural. Misconceptions about mental health disincentivize the public from wanting to pay for care. That has led to inadequate funding for mental health research. despite health parity laws, it has kept insurance coverage insufficient. It has also created vast disparities in the delivery of mental health services. In the US, again, for example, a person's ability to engage with the mental health system largely depends on who they are. Most racial and ethnic minority groups, for instance, are affected by mental health disorders at similar rates as their white American counterparts, and yet they suffer disproportionately higher consequences of these conditions, in part because they are far less likely to receive needed health care. For example, in 2015, among adults with mental illness, 48% of whites received mental health services, and that's compared with 31% for blacks and Hispanics and 22% for Asians. The reasons for such disparities include lack of health insurance, language barriers, which was alluded to in a talk this morning, and a shortage of healthcare providers who are equipped to meet patients' cultural needs. Systematic oppression has also deterred many Americans from pursuing mental health treatments. Historically, African American youths with psychiatric disorders have a higher likelihood of being referred to the juvenile justice system, while white youths are more likely to be referred for treatment. African American adults are also more likely to be involuntarily committed, and this kind of discrimination contributes to cultural mistrust and often an avoidance of the mental health care system. Access to mental health care also depends on where you live. The presence of mental health disorders is roughly the same in rural and urban areas. However, research suggests that people in urban areas are more likely to receive general mental health services than their rural counterparts. A number of factors contribute to this important disparity. People in rural areas are less likely to recognize a mental health condition. And when they do seek mental health treatment, they're less likely to be insured for it. Many have to travel long distances to be seen by the mental health professionals. And they tend to be concentrated only in the urban centers. In fact, a recent published study found that almost half of the non-metropolitan counties in the United States do not even have a single psychiatrist. Half. In rural areas, 65% of counties have none. The pervasive treatment gap means that in many places, mental health care is seen as a last resort. It orients communities towards a crisis response rather than a coordinated approach to prevention. And this reality leads to a vicious cycle that undermines the health and well-being of entire populations. So this takes us to an inflection point. And this is the key point here, that there's no question that we've reached this inflection point in a mental health crisis. But we're also in a unique moment in time now where we have the ability to address it. And it's why a conference like this is so important, because this is the step towards using technology to address this moment in time. As you've heard, emerging digital technologies have the potential to revolutionize the way we diagnose and the way we treat mental illness, especially for groups of individuals who have been traditionally hard to reach. One of these groups are veterans. PTSD has reached staggering levels in the American military, triggering serious mental health problems like depression, substance abuse, and suicide. Apart from reduced quality of life, military service members and veterans have PTSD risks, and they risk losing their jobs, their family, and having family dysfunction, homelessness, and higher risks for incarceration. And in spite of this gap and in spite of these vulnerabilities, an estimated 40 to 50% of veterans who are in need of mental health services do not receive them. And many who initiate mental health treatment wind up dropping out of services prematurely. One of the greatest barriers in this population is proximity. And it relates to what I was referring to around the lack of expertise in rural communities and counties. Currently, more than 3 million of America's 8 million veterans live in rural areas, forcing them, if they need to access care, to drive long distances to receive that care. In an effort to address this gap, the VA, as an example, is dramatically expanding its use of telemedicine. And one of the most common methods in clinical is clinical video teleconferencing, or CVT, which lets patients talk face-to-face with providers in the comfort and privacy of their own homes, and that so far the results have been promising, showing that telemedicine can provide the same or similar quality of PTSD care that a patient would get in a doctor's office. And you saw some of that reflected in the conversation in the panel this morning. Based on this early success, the VA is currently working on launching an additional pilot project to deliver PTSD therapy and other cares to more veterans and in more rural parts of the country. And here in this pilot study, participants are able to choose between cognitive processing therapy and prolonged exposure therapy, which are just two of the main forms of evidence-based trauma-informed psychotherapy. And veterans in these programs are assigned a care manager or coach who helps them assess services by off-site psychiatrists and psychologists. And their psychotherapists and the psychotherapy can also be delivered via interactive video from a VA medical center to the patient's home or to an nearby outpatient clinic. So, telemedicine is one form of technology that is expanding mental health care access to civilians as well as veterans. It's been shown to mitigate the barrier of stigma, and it can mitigate the shortage of health professionals in certain parts of the country. And it can also make services more affordable and convenient for patients. Of course, as you've heard, this modality of care has its own challenges. Telemedicine requires additional training, administrative support, and technological expenses that don't always apply in the in-person care setting. Many patients, as you've heard mentioned in the earlier session, don't have the broadband internet services to make virtual services feasible. And that's true, Vikram. As you travel across the country, you'll even see if you go to a Kmart in a rural community, when you're checking out at the counter, it takes a lot longer for that credit card to be processed. And that's really a function of the disparity, the differential in the bandwidth that exists, even in the commerce area. In urban versus rural settings. And so you can imagine how important the broadband access gap is, the disparity gap is in many parts of rural America. So in the future, what will have to happen if telemedicine is to be adequately deployed in these areas with limited broadband, we'll have to be mindful of issues related to payers, providers, and policymakers who will have to work together to make telemedicine one of the viable treatment alternatives, and to do so on scale in ways that will involve our studying and addressing the barriers to implementation on scale. I also want to make a point that advanced data analytics also hold a great promise for diagnosis and treatment in mental health conditions. And we are seeing some of this promise up close at our school. On this slide, I'm showing one of our colleagues, J.P. Ornella, an associate professor in our Department of Biostatistics, who is a pioneer of statistical network science. He is someone recently asked J.P., and the question was, if you had to design an ideal research tool, what would it look like? And essentially, JP's response was that this tool would have to be a ubiquitous device. It would have to be something that serves actual function or multiple functions so that we'd want to keep it with us at all times. It would track all kinds of granular details about our lives, our mobility, our sleep patterns, our social interactions, our access to green space, and more. In other words, JP's response to the question was that tool would look a lot like our smartphones. And each of you undoubtedly have a smartphone in your pocket, or maybe even right now in your hands. Today, 3/4 of Americans own a smartphone, and that's up from 35% just 7 years ago. Most of us, myself included, are completely dependent on these devices to organize and navigate our daily lives. As a byproduct, we've become walking databases, generating rich, real-time tapestry of our behavioral data. And these digital fingerprints reflect our actual lived experience in our natural environments, and as a result, they can be used to develop precise disease phenotypes and markers to diagnosis for treatment and illness. Digital phenotyping, a term that's relatively new. We weren't certainly using terms like this in the public health curriculum 30 years ago. This new approach to understanding behavior and phenotyping behavior holds a special promise in the field of psychiatry. Picture this. A psychiatric patient is having a difficult day. Her phone shows very little activity. The GPS sensor tracks her going slowly from room to room around her house. She doesn't check her email. She doesn't make any calls. Her only communication with the outside world is a takeout order on Grubhub. The next day, that same patient's phone shows a flurry of activity. More than a dozen quick, seemingly aimless trips outside of the house. Phone calls to people she hasn't spoken with in months. 3 hours of sleep, a string of Amazon purchases in the wee hours of the morning. All of these data are sent back to her doctor's office, where a quick data analysis triggers a suspected diagnosis. Suspected bipolar, in manic mode, with a crash coming any day now. That's the kind of life-saving diagnosis that J.P. Ornella believes we'll someday be able to make using smartphones. And his research is showing promise of this aspiration every day. His team worked with software developers to create an app that measures passive data, like how many hours you sleep, along with active data like voice memos and typed notes. And the results could be used to produce accurate diagnostic judgments. And eventually, the hope is that we could this data could even tell us how well treatments are working. In the past, it's taken months to assess the effect of a psychiatric drug. Providers have had to rely on what the patient self-reports about his or her mood or symptoms. And of course, many of us know that our own recollections, despite best efforts of what we've done and how we feel, can tend to be reported with error, if not bias. But for patients who are willing to have their activities tracked, smartphones, sensors offer us an opportunity to have objective assessments of how they're doing and what they're doing. And they can help flag symptoms like sleeplessness and lethargy objectively. And that data can also help us fine-tune medications and treatment dosage and provide people with more precise insights into their own condition and allow for more precise care. This example is just one of the groundbreaking research happening in the field of psychiatry. And over the next 2 days, you're going to be engaged in a variety of innovative talks that have the potential to transform the way we approach mental health in the United States and across the globe. And we know that the next big breakthroughs are really just at the threshold, likely being seeded by the postdocs, the junior faculty, and the senior faculty members in this very room. It's up to us to ensure that these breakthroughs aren't confined to our research laboratories, to our hospital beds, to the doctor's offices, and to our classrooms. We're obligated to be sure that we work across the disciplines and across these different domains to be sure that we can address this crisis and do so on scale. That means that we have to, as we are doing here in this conference, acknowledging the complexity and the connections between the mind and the body. And we have to work to integrate mental and physical health care and wellness into all that we do. It means navigating through ethical issues around data collection and human privacy and individual privacy. It means designing policies to address mental health, not just mental illness. It means shifting our collective approach from one of crisis response to crisis prevention. And it means working to dismantle the stigma and the shame that precludes so many people from getting the treatment that they need. All of us have a role to play, from training providers to educating communities to opening up about our own personal and mental health struggles. And this conference, for me, is a testament to the great promise that exists in psychiatry today. And together, we can and we must make this promise a reality. So thank you for your attention.